right, so I have quite a few slides. When they told me I was giving this talk, they didn't actually tell me how much time I had, so I just threw in everything. So there are some ways we're going to get around it. One of which is I have a way to jump through the cases I have here. So I will ask for the audience's vote on which cases I do in the room. I have two of my favorites, and then I'll let you guys pick another one. Okay. So the objectives of this talk, at the end of this talk, I would hope that you would be able to talk a little bit about the EPI related to STDs in adolescents in our region of the United States. And then also talk about some key strategies to optimize your visit time with them, describe the common presentations of common STDs, and Dr. Hook actually touched on a lot of them earlier on, and we're just going to talk about a few key scenarios in adolescents just to sort of reinforce that. And then also describe some public health measures that you as providers might be able to adopt in order to improve your care of adolescents. No major disclosures here, but I will be talking about the use of extragenital testing, specifically NAT testing, which has not been FDA approved for extragenital sites, but may have been validated by your lab. Okay, so it looks like I'm starting off with a question, and I need major IT help with this.
Where are we? Is that it?
Okay, yeah, great. Which of the following are risk factors for STIs in adolescents? Great, you guys are doing an awesome job. All right.
It's pretty obvious. All right.
Here's everything.
We're gonna back to you.
Yeah, back to the slides.
Okay. We just gave away the second question.
Oh, sorry. We'll get back to that.
Oh, yeah. All right.
This is why I didn't do this myself. Okay, so adolescents. So you're probably wondering, okay, so who are adolescents? So these are individuals who are in their pubertal stage and then going up to young adulthood, going into adulthood. So that range is somewhere between 10 and 19. It varies depending on what guidelines you look at. Some people say it goes on beyond that period, which could be true in some instances. So STIs are a major problem for adolescents, and we know that they frequently engage in unprotected intercourse. This might be due to issues with actually negotiating condom use, which is a big problem that might take place depending specifically if you have partner dynamics in terms of age, where one partner is older than the other. And then engagement in multiple partnerships. Now, this might be concurrent relationships where you have more than one relationship going on at the same time, or it might be serial monogamy, which is a lot of what we see in adolescents, each of which have their associated risk factors for STDs. And then barriers to STD education and confidential services. And this is a key point because we know that, for instance, in the state of North Carolina, we have a very robust STD education program, but there's some variability across the state as to how that's actually executed. So this might actually impact what adolescents know. And then confidential services, access to that is also really important. And then there might be biological factors associated with susceptibility to infections. For instance, in young women, the presence of ectopy puts them at risk for instance, STD infections like chlamydia. They're also not well estrogenized, so that means they're not lubricating as well in the vaginas, so that can also put you at risk for tears and cuts, which can lead to STD acquisition as well. So all these factors sort of come into play. And what we do know when we sort of put it all together is that adolescents might actually acquire their knowledge a little bit too late, in that females might actually be introduced to the subject of an STD through actually acquiring an STD, which is definitely the wrong order because that impacts your ability to do preventative services, make sure individuals get treated. So we definitely need to flip that dialogue and make sure that we get to them early, talk about prevention and counseling early in order to get them linked into care. Because we do know that people are having sex and they're having sex early. And this is data from the National Youth Risk Behavior Survey in 2015. And you can see as individuals progress through high school, there's increased sexual activity. And this is the same regardless of gender, regardless of race, ethnicity, pretty much the same trend is happening. And this puts them at risk for STDs. And specifically, we're talking about not using condoms. So 43% are not using condoms the last time they had sex. 21% are using, having sex and using alcohol. And 10% haven't been tested for HIV. And then there's about 14% of individuals that have not used any type of barrier protection to protect against pregnancy. So definitely a lot of factors that are at play here. So another question. And hopefully you forgot that we showed this before, but so this brings up a key point here in that the right answer, did we click on the right answer? The right answer here is that wealth disparities translate into health disparities. And we'll touch on a few of these other points here in the slide as well. Sorry, I think I may be talking a little bit too fast for you today. All right, so the burden of STDs. So we know that youth make up about 27% of our sexually active population, but they make up about 50% of our incident STDs, which is a big deal. And when we talk about incident STDs, they're particularly disproportionately represented amongst our gonorrhea cases, our chlamydia cases, about half of our HPV and genital herpes cases, and about a quarter of our HIV and syphilis cases. And then when we look at the map of the United States, you will see that there are a great deal of disparities depending on the region of the country you're in. So you can see that the southern portions of the United States, represented by the dark blue, are highly burdened by STDs. And we're in North Carolina, so you might not be able to see the numbers associated with that, but the dark pigment there suggests that that is a high morbidity state. We're doing worse than a lot of other places in that we have a high morbidity for both gonorrhea and chlamydia for men and women. And there might be factors associated with this. One of them is, like I said, the whole wealth disparity issue, which unfortunately here in the South is something that we deal with a lot and can impact individuals' ability to engage in care and also interact with the healthcare system. The same thing applies for HIV. Again, we're in a highly morbid zone for HIV, and you can see in North Carolina we have a higher rate than the national rate for HIV acquisition. And when we look at the individuals that are impacted in our state, we're talking about men who have sex with men. We're talking about our youth who might not necessarily engage in care, and we also have a subset of individuals who don't even know their HIV status. So when we put this all together, it's important to look at this through a social lens. So when you look at this, this is data from our surveillance report for North Carolina from 2015, and you will see that 17% of North Carolinians were below the poverty rate. And this is higher than we see nationally. And then when we look at the disparities that might exist, we can see that more female than male, and we can see that more youth than adults are impacted by this. And that there are disparities in that people of color are also largely represented within this poverty bracket. And I think one of the areas that we see this probably most significantly is with HIV and syphilis. And you can see represented on this graph, this is a portion of census tract people living at poverty level, and you can see that the poorest section of our population here in North Carolina are largely represented as our HIV and our syphilis cases. And then another group we have to keep an eye out for are LGBTQ youth, in that nationwide we have 88% of individuals who identify as heterosexual, and we have a very small, so we have a sexual minority here in our students that identify as other. And they are the minority there, but they have the majority of problems or barriers when it comes to seeking care. And some of that has to do with our non-discrimination laws across the country, as well as anti-LGBT laws. And in the South, historically, we haven't been so good at protecting that population. And this is really an issue because we know that, for instance, there's a high burden of depression, suicidality, a higher rate of substance abuse than some other youth, and then also higher risky sexual behaviors. And so this is where it comes in that it's really important for us to obtain a really confidential, comprehensive STD evaluation to make sure that we not only figure out what their risks are, we also look at their strengths and their assets so that they can actually overcome their risk factors. So some tips on how to do this in adolescents, as illustrated here in this image. Give that a shot. And so about confidentiality. So about 50 states in the District of Columbia allow minors to consent to STD services. 11 states require a minor to be of a certain age for consent. 31 states include an HIV package and an STD package for minors, which may require consent. 18 states allow but do not require physicians to inform parents about a minor seeking care for STD services. So here in North Carolina, a minor has the ability to consent for STD services, pregnancy-related services, mental health-related services, substance abuse services. So we're doing pretty good on that end. But we know that when individuals encounter barriers, it might prevent them from engaging with care, and then foregoing care, because of this whole parental consent part, can actually impact the outcome in terms of risk for STDs or not getting the appropriate screenings. Example here is illustrated here. So this was a recent report that came in MMWR, and we It was looking at individuals who were sexually experienced, females and males aged 15 to 25, who would not seek sexual or reproductive health care because their parents might find out. So in all, in looking at the data, the age group that was most disproportionately burdened by this were our young individuals. So age 15 to 17, 22% of individuals would not seek care because they were concerned about confidentiality, about their parents actually finding out about them seeking STD services, which is really sad because the individuals that did actually get that one-on-one time with the physicians, we saw that they got appropriate screening and testing and were linked into care as compared to others that didn't. So this is a real barrier that we need to consider when we're taking care of adolescents and assuring them that they can have confidential STD services. And one of the safe places for this to be done is a health department. So you guys are all in a good spot. There are some exceptions to the rule, of course, and these are obvious ones. When there's any concern about abuse, when there's risk of harm to self or others, definitely these are things you want to alert authorities to. And then also there's confidential reporting for STDs in the health department setting that we all are aware of. So how do you approach it? So key strategies. So you want to talk to individuals at their developmental level. You don't want to talk above them because that's really not going to get the job done. You want to discuss confidentiality with the parent in the room and the kids. So you want to talk to them about the rules of engagement of the visit. During this visit, this is what we're going to do. I'm going to want to talk to you privately about a few more specific things just to make sure we take good care of you today, and letting the parent know that up front that that particular interaction might take place. And then you want to do a brief risk assessment during that visit. You want to follow up on results, and you want to come up with that system before you get to that positive result. Talking to the youth about how do you want to know about your result when it comes in. We don't want that to be the insurance bill comes in and they see, this individual had chlamydia. That's just not the way to go about that notification process. So you want to come up with a plan before that happens. And then you want to make sure that that teen and the parent is also confident with that whole situation. And then in terms of other things I wanted to add, you want to make sure that you have a poker face. You are going to hear things once they feel comfortable with you. And you just want to make sure that you can sort of just listen, be that sounding board, and make sure they get linked into care. And normalize behavior. A lot of people are sexually active. We just want to make sure you're safe in doing what you're doing. Tell us a little bit more. There are lots of tools at your disposal. And Dr. Addix talked about this earlier on, the 5 Ps, in that we want to talk about partners, mainly so that we can know a little bit about who they're having sex with and how we can better serve them in terms of making sure they get appropriate screening. We want to know their practices. The last time they had a sexual encounter, the last time they had sex of any kind, what were they doing? What kind of sex did they have? Past history of STDs is really important. We know that an individual who's had one STD is more likely to have another one, and that there can be associated conditions associated with recurrent STDs. We also know that a new STD can also put you at risk for HIV acquisition in certain populations too, so we want that data. We want to know what they did to protect themselves against STD, if they did anything at all. Are they aware of what they can do to protect themselves against an STD? And you want to talk pregnancy plans, which is key. What are they using to prevent against pregnancy? Or in some instances, there is a desire for pregnancy, and this would be a great time to discuss it so that everybody's on board before that happens. There are some additional tools I have listed here that are used in adolescents specifically, and you can use whatever works for you, but the job, basically, the ask here is that you make sure that you hit all the key points. And I have another question. Next. Okay, routine screening for chlamydia and gonorrhea is recommended for sexually active women less than 25. I know you've got this because this was reinforced earlier on, so we're just making sure we pick this up and document that you got this part sorted out. Okay, great. Great answer. Okay, so that gets us to screening, and you guys got the answer right. So you know that individuals who are less than 26, they should be screened annually for gonorrhea and chlamydia. For our HIV-infected women, you want to make sure they're screened for trichomonas. The same does not apply to our HIV-infected men. You want to make sure that your highest risk women are also screened for syphilis, and we're in a high morbidity area, so that's really important. Also, hepatitis B screening, especially if the individual is pregnant, and Hep C screening if high risk. And when I say high risk, I'm talking about multiple partners. I'm also talking about intravenous drug use and that risk factor as well, or if they have a partner who's positive for one of those things. Now for men, as Dr. Hook pointed out, we really don't have any clear guidance here, so it boils down to the risk within the individual and what they're doing and the likelihood of exposure. So I have some guidance listed here. In general, we want to make sure that individuals are screened at their site of exposure when it comes to men who have sex with men, and make sure that we also get some of the specialized testing on board, syphilis, hepatitis as well. And then some general guidance. Pretty much everybody should have an HIV test, and it should probably start in adolescence. And we should do that going on into adulthood. Everybody should know their status. So normalizing testing also makes it a lot easier to get your job done. In terms of frequency of screening, generally it is associated with risk. So individuals who are more risky need more frequent screening. So every 3 to 6 months, perhaps. And then don't forget about the contacts, because if you don't treat the contacts, you're sort of going to hit the cycle of re-exposure really quickly. And so we screen because we know that the people that come into our office, that's the tip of the iceberg. These are the people who are symptomatic and they're coming in because something's annoying them. But we have this huge population of individuals who are asymptomatic that are really our pool of individuals who are going to go out and cause a problem in terms of creating more infections within the community if those individuals are not treated. So screening is really important. And that leads me to my cases. So I get first dibs and I go with case number 4 and case number 1. So in the room, case 2 or case 3? Okay, I'll try to go through everything as fast as possible. I somehow suspected that this would happen. So.
We're getting tangled.
Oh yeah. Okay. All right.
Here, let's do it there.
All right. Okay. So we have a 16-year-old that's coming in for her visit. She has absolutely no past medical history. She's coming in with a week of vaginal discharge. We do the 5 Ps with her and we find out she has 1 male partner in the last 2 months. We have 2 male partners in the last year. She's not using condoms, no contraception, sites of exposure are vaginal only, and unknown STD risk testing previously. You examine her, she's afebrile. When you go to do her pelvic exam, you find that she has a friable cervix, there's a mucopurulent discharge. Nothing going on bimanual examination. You do a wet mount, and the wet mount is showing a lot of white cells, but nothing else. So what is going on here? Well, if you guessed the cervix on the left, that would be a good shot at this one. So cervicitis. So this is what we're dealing with. We're talking about a mucopurulent discharge. We're talking about sustained endocervical bleeding when the swab is induced in the os. So that's sort of rubbing the swab across the os and seeing bleeding that's not just temporary. And then you can also have other associated urinary complaints as well. Discharge, intermenstrual bleeding, and then leukorrhea might be present. So the presence of white cells on vaginal wet mount. Etiologies, well, we talked about a lot of them earlier on. So chlamydia and gonorrhea are the ones we hear about a lot. Trichomonas can also cause it. Mycoplasma genitalium is a new emergent pathogen that we're seeing causing this as well, herpes. But about 60% of this is unknown. And then there are also the non-infectious factors, which I think are really important, especially in individuals who are developmentally younger. We want to talk to them about what they're doing to their vaginas or what they're putting in. So this could involve chemicals or topicals. This could involve toys. This could involve condoms or lubricants. All of these things can cause irritation, which can also mimic cervicitis. So we need to make sure we ask these key questions as well. So treatment. Treatment boils down to azithromycin. And then doxycycline as well can be used, but not in pregnancy. But I did mention that we're in a high morbidity zone. So because of our high morbidity zone, we want to make sure we cover for gonorrhea at the same time in a lot of the cases that we see here in the South. And then keep in mind other potential etiologies if things don't improve and you don't have that testing on board for a diagnosis. So to sum up that case, you want to make sure that during this visit, because she said she's using no barrier protection, you want to make sure that we do a pregnancy test. That's really important. And if the pregnancy test is negative, don't stop there. This is the opportunity for you to talk about how to protect against pregnancy if that is the true desire. It might not be the true desire, but you could put that out there. You want to offer comprehensive STD testing. And she's within the age group that we're going to be doing our gonorrhea and chlamydia testing. Because we're in a high morbidity zone, I'd probably treat her for gonorrhea and chlamydia at the same time. And then you want to recommend that she refrains from sex for at least about 7 days and that she encourage her partners to come in for treatment. Because she is at high risk for infection, and I'll show you her results in a little bit, you want to make sure that she's restrained. And you also want to give her the appropriate referral. So if you're in a health department setting and she needs to go to family planning, set her up with that. She's 16. Did she get all of her STD-associated vaccines? You might want to set her up with that, just to make sure that she gets all of these needs taken care of in this visit. You might not be able to do it in that room, but at least you can get her to some place where she can get it done. So this is the prevention part of it. Condoms are great, but that's not the full story. Condoms are pretty much user dependent. So if they're not used correctly, they don't work. If you don't use them, they don't work. So you want to have a backup plan, and you want to make sure that teen is down with that strategy. So talk to them a little bit about other options that are out there. Don't just stop at condoms. You want to talk about other things as well. And they have some examples listed here. So her testing came back positive for chlamydia. So what do you have at your disposal? So you still have a partner here, right? So she didn't get chlamydia just magically. There's somebody out there in her community, one of her sex partners. I see some people laughing. There are some individuals that probably believe that magic is involved in that. But yeah, so you want to make sure that the partners get in and they get tested and treated as well. So how can you do this? So you have a patient referral. So telling the patient, hey, can you bring your partners in for some testing? That might work, or it might not. There's anonymous internet-based partner notification, which is available, where partners will get a notice saying that you've been exposed to an STD. You might want to get that checked out. There is clinic-based referral systems. We have cards that we sometimes give to patients where they can use that. Contact cards. That's also probably not the most ideal way to find out that you were exposed to chlamydia. And then we also have, bring your own partner type of deal. Come into clinic, bring your partner with you. We could just deal with this at the same time so that we don't have this disconnect between one partner being treated and the other partner not. Okay, next question. Sorry. Okay, so EPT, is it permissible in North Carolina for partner management of chlamydia infections? Huh, interesting. Does everybody know what EPT is? I take it so. Okay.
Looks like it's true.
All right.
Back to the show.
Seems that there were a small portion of doubters in that group. So hopefully I can bring you back on board with this. So EPT is expedited partner therapy, which is the delivery of medications or prescriptions by persons infected with an STD to their sex partners without that clinical assessment taking place. In North Carolina, it is permissive in that if you have an index case who's diagnosed with chlamydia, you can use EPT. If that individual has been examined at your facility, you can be the one to provide that prescription. There are some caveats to it in that in the state of North Carolina, we say this is limited to heterosexual partners, and it's different in other states. And we also want to make sure it's a scenario where that individual, the partner is not going to come in for any type of testing or treatment. So ideally, you would want the individual to come in, but if they can't, this is something that you can use. And it's limited to one prescription, and you need to have the information about the partner in order to put it on the prescription as well. So there are some things that make EPT a little bit challenging to use in a clinic setting, but it's definitely a really important tool to have on board. So what about EPT in youth? Well, it has been studied and found to be effective in decreasing this whole reinfection cycle. It's been studied in men as early as 16 and women as early as 14 and found to be effective. So it's definitely something that you can use in an adolescent population. So don't discount them. This is something that you can use for them too. And I put this map up here because I wanted to highlight that there are still some states where it is prohibited. So if you practice in other states, you'd probably want to check this map because this keeps on updating and changing. But for the most part, I would say since I've been giving these talks, this map has definitely been becoming more green, which is good because I think EPT is a great tool to have at your disposal. Because we know that reinfection is pretty common. And when it comes to chlamydia, this is data from the Baltimore City system, and they looked at over 10,000 sexually active adolescents who attended a school-based health center. They found that close to 900 of those kids had chlamydia, and that they had about 230 had more than one subsequent episode of chlamydia infection. And the incident rate within a year period was about 26%. When they looked at the range over the whole study period, it was up to 38%, which is pretty high. And a young age at first infection was one of the factors that was strongly associated with this. And this is additional data sort of reinforcing this really common phenomenon regarding chlamydial infections. So in this data by Hosenfeld and al., they basically looked at gonorrhea and chlamydia infections in women in a systematic review, and they found that the likelihood of reinfection was pretty high, up to 14 months. Sorry, reinfection was pretty high, and this went out to the 8 to 10 month period is when you saw it peak at around 20%. And so that sort of brought up, like, when is the most appropriate time to screen? So generally, from this study, they took less than 6 months. So our current guidance is every 3 months, and you could see where that comes from. It comes from data such as this, and that we know that reinfection is pretty common, so we need to keep this in mind. So screening is good. You've done your job with that first episode, but you need to make sure that you also rescreen as well within 3 months. And we don't do so good with that part as providers. All right. We are moving on. Seeing that you guys selected all the cases, I'm going to blaze through them. Case 2. Same patient. She comes back in for her 3-month follow-up visit. You're actually going to rescreen her. She reports that she's having some lower abdominal pain now. She's not having any fever, nausea, or vomiting. She's had the same male partner since the last visit. She's not using condoms still. She's not using contraception. She never made it to that family planning visit. Sites of exposure are still vaginal only, and her partner was not treated. So you review the 5 Ps, really nothing different there. And on exam this time, the difference is that you notice that she has some cervical motion tenderness. The wet mount, you're still seeing a lot of whites there. So you guys probably know what she has, right? PID, yeah. So she has PID, and this is really something that we need to keep in mind with individuals who haven't been treated, who come in with these infections. It's really the most dreaded STD complication in women. It's an ascending infection that starts from the cervix and then can go out to the reproductive system into the pelvic area, and involves a spectrum of inflammation within that system, and it is often underdiagnosed. In terms of symptoms, and part of the reason why it's probably underdiagnosed is we have this whole subclinical component to PID where an individual might not even know that all of this massive inflammation is going on within the system. And when we look at data across the United States, it's estimated to occur 750,000 US women annually. It has been decreasing, and that was, you saw Dr. Hook's slides earlier on, also illustrated here as well. It's pretty costly. $4.2 billion in annual costs, so huge deal. So definitely something we need to keep an eye out for and make sure that we get individuals treated early to prevent this potential complication. So what are some of the risk factors? Well, you're in an adolescent talk, so I'm talking about this because adolescence is actually a risk factor, and it's not the age in and of itself. Part of it is age. Well, as I showed you in the maps earlier, a lot of young folks are having sex, and we have the highest rates of gonorrhea and chlamydia in our individuals less than the age of 25. So their pool of sexual partners is a higher morbid risk group than the larger pool. So the likelihood they'll encounter somebody with an STD is higher. And then there's also the biological factors that I mentioned earlier. Other things, history of PID puts you at risk for an additional episode, mainly because of the existing inflammation and damage that's already there. The obvious, having an infected partner with gonorrhea and chlamydia, multiple partners, current douching, and this is more because, again, of the issues with vaginal flora being interrupted and sort of pushing the bacteria up into the system as well. I have insertion of IUD. Notice I mentioned insertion, not the presence of. So the main risk for PID is going to be within the early portion of that IUD being in place and not like a month later. Bacterial vaginosis is one that we often forget about. Oral contraceptive use, mainly because of that issue of ectopy that can happen with oral contraceptive use. And then there's demographics, and we talked about that a little bit earlier on in terms of risks within that group, not accessing care in time, and then also not getting treated in time. And to highlight some of these things, so this is also data from MMWR in 2017 looking at the prevalence of PID in sexually experienced women of reproductive age in the United States. And you will see these arrows here that I have that really the youngest groups are the ones that are most at risk for PID within that, or the most prevalent PID is within that group. And then having a lot of partners is definitely a risk factor for PID. And then the previous diagnosis of an STD as well. So diagnosis, well, often missed due to lack of symptoms. I talked on that a little bit earlier. A lack of awareness on the provider end because of the asymptomatic or the nonspecific nature of the disease. And then with that all in place, we should keep in mind that if we have an individual that meets these clinical criteria for PID, we want to get them treated up front to prevent these associated complications. So the criteria include uterine tenderness, adnexal tenderness, and cervical motion tenderness, of which the most sensitive is the adnexal tenderness here. And then other additional factors that might be present, having a fever, having this abnormal discharge that I mentioned earlier on, and then elevated inflammatory markers. Those are not things we typically have access to in a health department setting, but if you had those in addition, that would also support the diagnosis. And then, of course, having an organism that can be associated with PID like gonorrhea and chlamydia. So this is just to highlight some of the reproductive consequences, which can be tubal scarring in up to 8% of individuals, ectopic pregnancy in up to 9% of individuals, and chronic pelvic pain as well in 18% of individuals. The treatment, as we highlighted earlier, is going to be ceftriaxone and doxycycline plus minus metronidazole. I would say for the most part, a lot of providers use metronidazole because of that concern that PID can sometimes be a polymicrobial infection, and there are concerns that you want to make sure you get the anaerobic bacteria as well. So that's where the flagell component comes in. And you probably also need to be aware of instances where you want to make sure that individual gets linked into a hospital system. And that's when you cannot exclude a surgical emergency. When you suspect that individual might have an abscess on one of their ovaries, where their individual might be pregnant because they're at risk for complications. If they have severe illness, like if they're not able to tolerate PO medication, that's definitely a warning sign that they might need to be linked into a hospital system. If you don't think they are able to follow the directions in order to complete their outpatient regimen, that's going to be one too. And if they fail to respond to outpatient therapy. But you will notice on this list that I did not put adolescents. So being a youth in and of itself is not an indication for hospitalization. That's one thing to keep in mind. And I did not put HIV as well. Indeed, HIV individuals are at risk for complications associated with PID, but generally it's not thought that they require hospitalization. If they have PID, they can still follow with the same regimens in the outpatient setting. So to summarize, so on our individuals come back in, you're going to do another pregnancy test because, again, she's not using condoms. You want to make sure that you exclude the possibility of pregnancy. You want to make sure you have a comprehensive STD history assessment on board and do the appropriate screening. You want to treat her appropriately. You want to try to get that partner in once again. Talk about safe sex practices, and then also discuss referrals and resources. And in the case of PID, you want to make sure you have follow-up on board within 72 hours at least. So making sure you have a contact number where you can get in touch with this individual, bring them back in to make sure everything is okay. And then because we know she has a diagnosis of an STD, we want to make sure that she also gets rescreening again in 3 months' time. Okay, blazing through these. Okay, we're on case number 3. Okay, 17-year-old HIV positive male comes into urgent care. He complains of a penile abrasion on his penis and he said he got it caught in his zipper. Okay, so you ask him about his sexual history and exposure because you know that that's really important. He said he's had sex with men and women historically, but not recently. One partner in the last 2 months and 3 in the last year were all male. Last sexual encounter, not really sure. I don't know, maybe 3 weeks ago. Sites of exposure describes oral and penis top, so he's anal insertive sex. And then condom use occasionally, maybe with his male partners, more than not. And then history of STDs. He's had a history of chlamydia 3 months ago. So you whittle through your diagnosis for differential genital ulcer, and Dr. Hook addressed some of these earlier on. So herpes, syphilis, that's usually the usual debate that we end up with here. And then other things, well, chancroid is relatively uncommon in the United States, so that would not be on the list. LGV, well, this person had chlamydia that was documented prior, but that was appropriately treated and apparently resolved. And then I have other things listed here. These are autoimmune inflammatory disorders, other things you want to keep in mind if you see an ulcer on the genitals. And then there's trauma. I mean, the dude did say that he got his penis caught in a zipper. That could cause an abrasion, right? So let's investigate this a little more. So you examine him. He's afebrile. He has bilateral non-tender lymphadenopathy. Okay, this is seeming less like a zipper abrasion. There's a penile lesion. It's 1.5 centimeters inside. It's ulcerated. It has an indurated border. There's a scant yellow exudate on top of it. And the lesion is slightly tender to palpation. Okay, so now we have this differential where we're trying to figure this out, and now we're down to, is this herpes or syphilis, right? We typically think of a painless ulcer on the penis associated with syphilis, but this individual is having pain. Could it be syphilis or not syphilis, or could it be something else? Could it be trauma? Well, we do some testing on him, and while we're waiting on this great testing to come back, we're going to treat this individual presumptively for syphilis. We're in a high morbidity zone, and syphilis is always on your differential. And because it could be herpes, this individual also gets some treatment for herpes as well. And then you send them out into the world, and you have your testing on board, and you find out that RPR is non-reactive. Okay, so we thought that this was syphilis, right? You did an HSV PCR on that lesion, it was negative. And then all other sites are negative too. So this puts us in a little bit of a diagnostic conundrum. Did you just give somebody an extra dose of penicillin? Well, let's talk a little bit about syphilis. So we talked about this a little earlier on when Dr. Hook was going through like the natural history of syphilis. And we know we have this exposure, we have this incubation period, after which you can go on to develop primary syphilis and then sort of move through like in the rule of threes from one step to the next. And that, you know, neurosyphilis, I just want to mention it can happen at every stage, but this is not a neurosyphilis case. But just wanted to highlight that syphilis, you know, it moves through stages. So you came up with the idea to repeat his RPR in 2 weeks, and his RPR has a titer of 1 to 8. What do you think? So what do you think about your testing? You think this is a false positive? No. Yeah, it just wasn't showing up. So the issue with testing that we have to keep in mind is that there are a few instances where you can have a non-reactive RPR where this person truly has syphilis and, you know, just the testing isn't showing that. And one of those instances is, for instance, if you had a prozone phenomenon, if you had such high titers or issues with that test functioning because of not being able to follow the usual antibody-antigen combination because the titer is really high and your lab just didn't titer out enough. So that's one. The other issue is that you tested too early. You tested too early within the performance of the test. And so I put this illustration, and I think you should be able to see it. So you can see that within the certain period when you're getting early on an infection, your dark field is probably going to be a test where you get a higher yield type of outcome. However, we don't do dark field in a lot of our health department settings. So we know that if we wait a little while longer and repeat that RPR, we can sometimes see that positive test because now we're within the performance of the test. So this is where we tell individuals, like, this test is negative, but I really think you have syphilis. Why don't we repeat this test in 2 to 4 weeks? And that's what happened with this individual. And then also we have this bell curve. So he's towards the lower end of this bell curve for his primary syphilis or early infection. So definitely one thing to keep in mind. So if it looks like syphilis and you're in a region of the country where syphilis is highly likely, you want to make sure that individual gets treated before they walk out of your door. Just some examples of chancres in different parts. So you have several penis chancres, you have a tongue chancre, and I believe that might be a hand chancre right there on the bottom. Secondary syphilis, we saw examples of this earlier on in different manifestation. You have that rash there, you have condyloma, you have some alopecia, you have the palms and the soles. And then a reminder about treatment, just to highlight this, we dealt with this earlier on. So making sure that early syphilis, they get treated with a benzathine penicillin, 1 injection. And then other treatment regimens I have listed here. Really important that that partner gets treated. So partners within the 90 days should be treated in this case. And remember that as of the current knowledge that we have, HIV-infected patients don't need additional shots of penicillin. But who knows, maybe we'll find some more information out about that. And I wanted to highlight this thing. So this individual in this case was HIV infected, but there's also this phenomenon that we know about, as Dr. Hook mentioned earlier on as well, that we have a fair amount of individuals who have syphilis who also have concurrent HIV. So this is really, those individuals are at within that prioritization category where we want to make sure those individuals get appropriate screening and linkage to care because they are at high risk for HIV acquisition. And then further highlighted here on this slide in that we know that the two are bedfellows essentially, and that there's this reciprocal relationship or partnership between HIV and syphilis that's out there, and that one increases the risk of the other. And an individual who has syphilis, that is sort of like a marker for ongoing risk behavior in that individual. So if you're having an individual who's coming back to you who has a new syphilis test and they said that they're doing everything they can, they're using barrier protection, there's really an opportunity to talk a little bit more about what they're doing to protect themselves, because getting a new diagnosis of syphilis indicates there's something that we might be missing in terms of our counseling, in terms of risk and harm reduction. So on this visit, you did your comprehensive STD testing, you gave them their bicillin, you make sure their partners got linked into care, you offer them condoms, you talk about referrals and resources, and in this case with an HIV-infected patient, you want to make sure they're linked into HIV care. Okay, last case. All right, done case. Okay, all right. So I'm just going to flip through these slides really quickly to encourage you to make sure that you do triple dip screening with all of your patients, site of exposure. And this individual, for instance, you want to make sure that they get appropriate linkage to care, that they get PrEP services to prevent HIV acquisition, and make sure they get appropriate STD-related vaccinations. You have these slides on board. Make sure you give them links to appropriate resources that are age-appropriate. And these are my take-home points. Thank you.
Is that one of yours?
Yeah, I think that's I don't think we did the last case, which was
Is that one?